Hello and welcome back. In this video, which is the ninth code in our 12 codes for ECG interpretation, we'll discuss the ST segment, which is very important and highly indicative of a wide variety of pathologies. As you know, this is the ST segment, which is an isoelectric segment normally representing the initial phase of ventricular repolarization. And as we have mentioned, the junctional point, the point where QRS complex and ST segment meet is called the J point, and it represents the isoelectric point of the heart. This is called J point, junctional point, which is the point where QRS complex and ST segment meets. So what are the ST segment patterns? Normally, ST segment is horizontal at the baseline, it's isoelectric, but sometimes in certain pathologies, ST segment may be elevated above the isoelectric line. We call it ST segment elevation. And in some pathologies, it will be depressed below the isoelectric or baseline, and it is called ST segment depression. Let's start with ST segment elevation. And in order to understand why myocardial infarction produces ST segment elevation, what we call STEMI, ST segment elevation myocardial infarction, ST segment elevation myocardial infarction. Let's understand the effect of ischemia on the cardiomyocyte or on the electrical activity of the heart. As you know, when there is ischemia, there is no oxygen supply to the heart. So there is no ATP. So there is inhibition of the action of the main pump in the heart, which is sodium, potassium, ATPase pump. And as you know, this pump function is to move 3 sodium out of the cell and 2 potassium in to help the cell to reach its resting membrane potential. When this pump is blocked, there is accumulation of sodium inside the cell. And as you know, sodium is a positive ion. So this will make the ischemic cell or the ischemic tissue is in a state of sustained depolarization. So the ischemic myocardium is in a state of sustained depolarization. I mean increased electrical activity, or what we call increased excitability due to more accumulation of sodium inside the cell and inability to move sodium outside it. So if there is a transmural infarction, as in cases of acute myocardial infarction, STEMI, the whole myocardium will show increased activity, in homogeneous increase in its activity, producing more electricity. As you know, the electrical activity moves from the endocardium to the epicardium. So it moves towards the electrode, which is here the V5 or V6, causing ST segment elevation. As we have mentioned, when the electricity come toward a certain lead, it produces a positive deflection. So here we will produce a positive deflection causing ST segment elevation. And consequently, the opposite or the mirror image leads will show ST segment depression, what we call reciprocal depression, something like this, what we call reciprocal depression. So when there is a transmural infarction, there is marked increase in the electrical activity and depolarization of the whole muscle, causing the electrical axis to go from the endocardium, from endocardium towards the epicardium towards the lead. So it causes ST segment elevation. Okay. What if there is a subendocardial ischemia, like in cases of unstable angina or non-STEMI? Here, this part only is affected by ischemia. So its electricity increase, its depolarization becomes more marked. And as you know, electrical activity transmit across the according to a voltage gradient from low voltage to high voltage. So here the electrical activity will move towards this. So it moves away from the electrodes, so produces ST segment depression like this. So when there is subendocardial ischemia, there is ST segment depression, but when there is a transmural infarction, there is ST segment elevation. This concept is very, very, very important to understand, to know why STEMI produces ST segment elevation and why non-STEMI or unstable angina produces ST segment depression. Let's go back to our presentation. So ST segment elevation is due to transmural myocardial infarction with its evolving pattern, but this evolving pattern is out of scope of this course. We will discuss it in the higher levels of the course. But be sure that not every ST segment elevation, not always acute myocardial infarction, there is a differential diagnosis. And for simplification, this is the mnemonic elevation. E electrolytes, and the most common one is hyperkalemia, producing ST segment elevation and hyperacute T. The second L is for left bundle branch block morphology, E for early repolarization, V for ventricular hypertrophy, A some forms of arrhythmias like Brugada syndrome, T Takotsubo, which is a broken heart syndrome, and traumatic brain injury in cases of intracranial hemorrhage, I infarction, I mean myocardial infarction or either injury, and also inflammation like myopericarditis. O is Osborne wave, which is present in situations of hypothermia. And finally, N, non-atherosclerotic vasospasm in situations where the coronary not obstructed by a thrombus, it's just spastic, producing a transient occlusion, then opening. So there is a wide variety of situations causing ST segment elevation, not just or not always acute myocardial infarction. According to the clinical situation and the risk factors in the patient, you should individualize your decision or interpretation. Okay, then we will move to ST segment depression. And also, ST segment depression has certain patterns. This depression may be a horizontal depression, and this is the pathognomonic pattern in cases of ischemic heart disease, as we have discussed early, in cases of subendocardial ischemia. And it may be a down-sloping depression, also denoting ischemia, and also down-sloping depression represents a strain pattern in cases of ventricular hypertrophy, either right or ventricular or left ventricular hypertrophy. And finally, upsloping depression, which is a benign situation, occurs mostly with tachycardia when your heart rate fires above 150 beats per minute, like during a treadmill exercise. Okay, let's see it. So it's characterized by down-sloping depression or upsloping depression and horizontal depression. And finally, there is a certain pattern of depression called sagging depression. It's like a sag, like a scoop you use, and this is pathognomonic in situations in patients using a digoxin. So it is called digoxin effect, and we will see all these now. In this pattern, this is the down-sloping depression, which represents the strain in left ventricular hypertrophy. This strain is present in lateral leads, V5 to V6, while in right ventricular hypertrophy, RV strain is present in anterior precordial leads in V1 to V5. And this down-sloping depression represents strain pattern. But take care, if you find this down-sloping depression in absence of voltage criteria of ventricular hypertrophy, it denotes also ischemia like horizontal depression. While this is the same patient showing isoelectric SC segment depression at rest, but while with exercise on the treadmill, there is upsloping depression, and this is a benign situation. This is the horizontal depression, ideal and typical for ischemia, subendocardial ischemia, as we have mentioned. And here is the sagging depression, like a sag of a scoop, and the sagging depression, like here, always present in the infralateral leads, is pathognomonic for digoxin use, and it is called digoxin effect. And when you see it, take care if, because the patient may develop a lanoxin or digoxin toxicity. Also, be sure that not all SC segment depression is ischemia. It may be ischemia, it may be strain, it may be digoxin effect, maybe due to hypokalemia or hypomagnesemia, maybe rate-related due to tachyarrhythmias, due to tachycardia, increased tachycardia, or combination of the above pathologies. So not every SC segment depression is ischemia. If you remember this fantastic slide that we have discussed earlier in this course, which is the anatomical grouping of the ECG leads, because here, when you find the SC segment elevation or depression in certain leads, you'll know which part of the myocardium is affected, which wall is affected, and consequently, which coronary vessel is occluded. All of this we have discussed earlier. And if you remember, these leads 2, 3, and AVF in the green color represents the inferior leads. The V1 and V2 in the blue color represents the septal lead. The V3 and V4 in the purple color represents the anterior leads, and always septal and anterior are affected due to occlusion of the left anterior descending LAD coronary artery, and the lateral leads, the V5, V6, 1, and AVL represents the lateral lead, which mostly supplied by the left circumflex artery, and as we have mentioned, that AVR gives a global image for all walls. So let's apply. If you look at this ECG, you will find a comb stone marked SC segment elevation in V1, V2, V3, V4, V5, and V6 in the septal, anterior, and the lateral leads. So this represents an extensive infarction, extensive left anterior descending artery occlusion, producing septal, anterior, and lateral infarction. And as we mentioned before, that always the opposite leads, which is the inferior leads, will show the mirror image, or what we call reciprocal depression. And the reciprocal presence of reciprocal depression is a sure sign for being in acute situation, not a chronic problem. If you look here, you will find ST segment elevation in the inferior leads, denoting occlusion of the right coronary artery. And here you find the reciprocal depression in the lateral leads in 1 and AVL. And as we mentioned, when you see a inferior infarction, you should do a right ECG, as we have discussed before, because it's commonly associated to find the inferior myocardial infarction with right ventricular infarction. And here you look at AV at V for right. If it shows SC segment elevation of one small square, it denotes a right infarction. And here you can see SC segment elevation in leads 1 and AVL. This denotes an isolated lateral infarction, and its mirror image or reciprocal depression is in the inferior leads 2, 3, and AVF. So this represents an isolated lateral infarction. I know that ST segment, one of the challenging situations in ECG. At first, we have known that SC segment is an isoelectric one, but sometimes there is pathology that produce SC segment elevation. some pathologies that produce ST segment depression, and ST segment depression may be a horizontal depression of ischemia, maybe down sloping depression, or maybe up sloping depression, and finally maybe sagging depression of lanoxin toxicity. I hope I have mentioned the concept very easy. Thank you very much and see you in the next video.